Okay. Good evening, friends, and welcome to this doctoral initiative of Clinical Thursday, where we'll study about all the relevant clinical scenarios. And I hope you're all enjoying these Clinical Thursdays that we are doing on every Thursday on DocTutorials YouTube channel. And just let me know quickly if you're comfortable with the audio and the video. Just tell me a quick yes if you can hear me clearly. Yeah. Is it audible, guys? Can we go ahead? Yeah. So be interactive. This is going to be a clinical case scenario, and we'll discuss some relevant topics in neuroradiology along with this. Hello, Palak, Arun, and Durga, Surya. So let's get started. Look at this clinical scenario. A 45-year-old widow presents with weakness in both legs and unsteady gait. Her family reports that her speech also has been slurred. Her condition has been progressively worsening since past few weeks. HIV testing performed at the hospitalization was positive with a CD4 count of 45. MRI brain was advised, which showed multiple high signal lesions in the parieto-occipital region as shown, and they gave you this MR image. What is the likely diagnosis? Is it a primary CNS lymphoma, HIV encephalitis, progressive multifocal leukoencephalopathy, or toxoplasmosis? Hello, Hari, and can anybody try this question? So let us go back to the question once again. This is a 45-year-old widow, and she's complaining of weakness in her legs and unsteady gait. There is slurred speech also. The condition is being progressively worsening for the past few weeks. HIV testing is positive. HIV is positive, and CD4 count is also less. An MR showed this image showing high signal intensity in the parieto-occipital region. What is the likely diagnosis? So HIV is a very common condition, right? So you need to know relevant points with HIV. Can you analyze this MRI? Okay, I got an answer of HIV encephalitis, one answer of toxoplasmosis. Anybody can try more? Just tell me, let us try to analyze the MRI. Let us look at this axial MRI and tell me, are these lesions unilateral or bilateral? Are these lesions unilateral or bilateral? What do you think? Is it unilateral or bilateral? So imagine a HIV patient coming to you with weakness and you're getting an MRI done and you're seeing this lesion. So you tell me, is it unilateral or bilateral? Just tell me unilateral or bilateral. What do you think? Unilateral or bilateral? These are bilateral, right? So both the places on both the hemispheres you're seeing. And is it symmetrical or asymmetrical? Are they equal or asymmetrical? Symmetrical or asymmetrical? Bilateral, agreed. Okay. Symmetrical or asymmetrical? This is, they're not equal, they are asymmetrical, right? So this is asymmetrical. So bilateral asymmetrical lesions. And what about the subcortical U fibers? So subcortical U fibers means these fibers, just these fibers, the subcortical U fibers. Are they involved or not? Are they involved? Do you think the subcortical U fibers are involved or not? The subcortical U fibers are also involved. The lesions are going and extending and involving the subcortical U fibers. So there is involvement of subcortical. There is involvement of the subcortical U fibers also. Right? And when you see an MR region, like which is more patchy, right? Bilateral, asymmetrical, involvement of subcortical U fibers in a HIV patient showing weakness with a poor CD4 count, right? CD4 count, which is just 45 in this patient here. This is suggestive of a progressive multifocal leukoencephalopathy, right? Manas was right. So this was the progressive multifocal leukoencephalopathy. Let us try to understand, right? Please remember, these are important scenarios with HIV that I want you to understand. So tomorrow in the exam, if you are getting a HIV patient and there are bilateral asymmetrical lesions, predominantly on the parieto-occipital, sometimes on the frontal also, but predominantly on the parieto-occipital region, involving subcortical U fibers, Please remember it as PML, progressive multifocal leukoencephalopathy. So progressive weakness was there, multifocal involvement, patchy involvement, white matter involvement, even the subcortical U fibers are involved. Progressive multifocal leukoencephalopathy. And can you tell me this progressive multifocal leukoencephalopathy, what is a causative agent? Anybody remembers the causative agent? Anybody remembers what is the causative agent for this condition? This is caused by a JC virus, right? So JC virus, a human polyoma virus, right? So the JC virus will cause this progressive multifocal leukoencephalopathy. How is the MRI showing? Bilateral involvement, asymmetrical involvement, right? Parieto-occipital region is predominantly involved. But if you are given bilateral symmetrical lesions, right, involving periventricular white matter, there is associated cerebral atrophy, which is sparing the subcortical U fibers. So if there is symmetrical involvement, periventricular white matter is involved, associated global cerebral atrophy is there, this is suggestive of HIV encephalitis. Now, let us try to understand this once again. So let us look at the question once again. There was progressive weakness in the patient, slurring of speech, weakness. The MR image, the clearly question said there was involvement of parieto-occipital region, right? And the image showed bilateral asymmetrical lesions. We called it progressive multifocal leukoencephalopathy. Let me show you more images. So look at here, bilateral asymmetrical involvement of parietal and occipital region, the subcortical fibers extending almost in the subcortical areas also, patchy involvement, right, multifocal involvement, asymmetrical involvement, all of this will be in favor of progressive multifocal leukoencephalopathy caused by the JC virus. Okay, so this is progressive multifocal leukoencephalopathy. In HIV encephalopathy, we'll have, look at the dilatation of the sulcal spaces, right? So there is cerebral atrophy. So what does this indicate? There is global cerebral atrophy. And how are the lesions? The lesions are classically bilateral but symmetrical. They are bilateral and symmetrical. You can see here, bilateral periventricular white matter is involved, symmetrical involvement is involved, and it is not extending towards the periphery, it is not extending into the subcortical U fibers. So the subcortical U fibers, are spared. The subcortical U fibers are spared. So when you see the lesions, right, which are bilateral, symmetrical, associated with cerebral atrophy, there is no involvement of subcortical U fibers. The subcortical U fibers are spared. This is HIV encephalopathy. Let me show you one more example. So look here. There is some widening of the sulcal spaces, right? Some cortical atrophy is there. The lesions are just periventricular. You hardly faintly see, you can see, appreciate here, just periventricular lesions, bilateral, symmetrical, right? So they are bilateral and symmetrical, more periventricular in appearance, okay? More periventricular. And these will appear normal on T1, a normal signal will be there on T1, right? And they are more periventricular. They are symmetrical, and they spare the subcortical U fibers. All of these, and they can be associated cerebral atrophy. All of these go in favor of what? HIV encephalopathy. So if I show you another images, look at this thing. So I'll tell you this is HIV patient, right? Now you tell me, what do you want to answer this if you're given this image? If you're given this MR image, I'll tell you this is an HIV patient and this image is given to you. What do you want to answer? This first image. How is the lesions? Are they bilateral? Are they symmetrical or not? Right? What do you want to answer this first one? Waiting for your answers. What is this first image? Do you want to call it as HIV encephalopathy or a progressive multifocal leukoencephalopathy? Anybody can try? Look at the MR image, look at the location being involved. They are periventricular, they are bilateral, symmetrical involvement. So this is what is HIV encephalopathy. And how is this? This is more patchy. This is multifocal, patchy involvement, bilateral but asymmetrical. So this is progressive multifocal leukoencephalopathy. So please remember how to identify the images. So HIV patient will be given to you, right? Poor CD4 count, immunocompromised state will be there. Look at the MR appearances that are given. And they can give you those wordings, okay? So they can give you those wordings where you are seeing this bilateral, symmetrical involvement, periventricular involvement, sparing of subcortical U fibers, favor HIV encephalopathy. But perito-occipital involvement, right? So more of a perito-occipital involvement, multiple bilateral but patchy involvement, asymmetrical involvement. Think of progressive multifocal leukoencephalopathy. Are you clear with this, right? Can you differentiate these two? Just tell me if you can differentiate these two whenever you get across a HIV positive patient with weakness. Is this clear, all of you? Comfortable? Right? Okay. So we'll look at few more conditions associated with HIV. So imagine there is a HIV positive patient and he is showing multiple ring enhancing lesions which are smaller. Okay, there are multiple ring enhancing lesions which are small, less than 4 centimeters. Involvement of basal ganglia is predominant, and there is an eccentric target sign showing a lactate peak. Beneath, I'll be discussing as we go forward. Okay, so just look at here. So imagine there is an HIV positive patient who is showing a multiple ring enhancing lesion which are smaller in size, right? Which are involving the basal ganglia, showing an eccentric target sign and lactate peak. What do you think is this answer? Anybody? If you're given, HIV is a very common condition and you need to know proper details about HIV, right? So a lot of questions will appear on the exam. And HIV positive patient, basal ganglia showing eccentric target sign, ring enhancing lesions, multiple small lesions, and a lactate peak. Anybody? Okay, let's look at the second one. You have not answered this. Let me see if you can answer this second one. Can you try this second one? A ring enhancing lesion, usually solitary but large periventricular location involving the basal ganglia. Corpus callosum involvement is seen. The lesions are hyperdense on CT, showing choline peak. What do you think? HIV positive patient, poor CD4 count, and showing ring enhancing lesions which are in the periventricular region involving the basal ganglia and the corpus callosum. It is the lesions are hyperdense on CT, showing choline peak. I think you finding it, difficult, right? So if you just go with the text or the theory, it looks difficult. Let us come to the images, okay? You'll get it better. At least, can you try this? Can you try this? Dilated perivascular spaces, Virchow-Robin spaces, the perivascular spaces are dilated, especially near the basal ganglia, and you're having gelatinous pseudocyst. So HIV positive patient is there, right? And he is having dilated perivascular spaces around the basal ganglia, gelatinous pseudocyst. Can anybody try this? I'll give you one clue. Soap bubble appearance. Soap bubble appearance. All this pseudocyst, this dilated perivascular spaces and this gelatinous pseudocyst, they give soap bubble appearance on MRI. Soap bubble appearance on the MRI brain. Anybody try? What is this? Okay. Let us, simplify this. Again, a very important clinical scenario, HIV positive patient, right? On the MR imaging, you're finding different findings. Let us get to this one by one. I'll ask you the same questions again towards the end. Hope you will do them right at the end. Okay, so concentrate carefully now. Just let us look at these images. Now look at here. These are multiple lesions, right? So multiple. And you are seeing these small lesions, right? And they are lesions predominantly at the basal ganglia. So they are lesions which are less than 4 centimeters. There is involvement of the basal ganglia. And if you get a contrast study done, you are seeing a ring enhancement. So you are seeing a ring enhancing lesion, ring enhancing. And you are seeing there is a eccentric target. So you are having a ring enhancing lesion showing a eccentric target sign. So you are seeing a eccentric target sign. This is suggestive of toxoplasmosis. So ring enhancing lesion in AIDS patient, we say, right? So ring enhancing lesions in AIDS patients, especially involving the basal ganglia. This is toxoplasmosis. Now you can look at another examples here. So you can see here this multiple ring enhancing lesions. You can appreciate the eccentric target sign. All of this is what is toxoplasmosis. Toxoplasmosis. Please remember the images. HIV positive patient, AIDS patient having this multiple small ring enhancing lesions showing eccentric target sign. This is toxoplasmosis. Now look at here. Again a HIV positive patient, poor CD4 count, but look at the imaging findings. You are getting a CT scan done and you can see the lesion is more white. It is hyperdense on CT. There is a lesion which is hyperdense on CT scan. So a very vascular or a very cellular lesion, okay, a very cellular lesion, high cellularity lesion would be hyperdense, right? So a hyperdense lesion on the CT scan. And you are seeing a ring enhancement. You are seeing a ring enhancement. There is a periventricular, a more solitary lesion. It is involving the corpus callosum. You can see it is invading the genu, right? It is invading the genu, invading the corpus callosum, involving or infiltrating the corpus callosum. Can you tell me any other lesion you know which involves the corpus callosum? Do you know any lesion that you know which involves corpus callosum? I taught you any brain tumors you know from your pathology, from your, radiology, or somewhere you studied any brain tumor which involves corpus callosum other than this one. So remember, even glioblastoma multiformis, right? So the aggressive cerebral glioma, right? The butterfly glioma can also invade the corpus callosum and cross the midline. And even you have this lesion, which is a primary CNS lymphoma, right? Which can be seen in HIV patients, right? So AIDS patients can have this hyperdense lesion on CT scan, which is appearing like a ring enhancing lesion, more solitary, large lesion, more than 4 centimeters. The difference is, toxoplasmosis, they are small, multiple. These are usually solitary and larger, more than 4 centimeter lesion. Both of them can be ring enhancing, right? Both of them occur in HIV AIDS patients, right? So it's important to understand these differences. This is primary CNS lymphoma, primary CNS lymphoma. Look at here. Here, on this MR image, in the region of the basal ganglia, bilaterally, the basal ganglia, they are showing dilated vascular spaces. You can see these are called as, dilated perivascular spaces. These are called as Virchow-Robin spaces. And gelatinous pseudocyst would be there here. These give the appearance of soap bubble appearance. Soap bubble appearance. So you can see here this classic soap bubble appearance on MRI brain. This is suggestive of cryptokorosis, right? Cryptokorosis. So this would be a soap bubble appearance. So these are dilated perivascular spaces in the region of the basal ganglia. So you can see all the images once again. Try to concentrate on the images. Then I'll ask you the same questions again. Look at the first one. Here you are seeing dilated perivascular spaces in the basal ganglia giving a soap bubble appearance. If you are seeing a hyperdense lesion on the CT scan, which is showing ring enhancement, involvement of the corpus callosum, more solitary, this is your primary CNS lymphoma. If you are seeing multiple lesions, especially in the basal ganglia, showing an eccentric target sign, think of toxoplasmosis, toxoplasmosis. So let us look at these things once again. If you are getting multiple ring enhancing lesions which are very small, showing involvement of the basal ganglia, having eccentric target sign and having a lactate peak because of the necrosis there, the lactate peak, this is toxoplasmosis, toxoplasmosis. So it's a HIV positive patient showing these multiple ring enhancing lesions. Think of toxoplasmosis. A ring enhancing lesion which is usually solitary, more than 4 centimeter, large lesion, periventricular location. You remember the image, right? So it was more periventricular, involving the basal ganglia, involving the corpus callosum, hyperdense on CT, and being tumor, it will have choline peak, right? A choline peak will be seen with tumors. So this is primary CNS lymphoma. Primary CNS lymphoma. This will be hyperdense, involves the corpus callosum and will show you choline peak. So lactate peak will be seen with toxoplasmosis. Choline peak is tumor seen with primary CNS lymphoma. And dilated perivascular spaces, the virtual Robin spaces, especially bilaterally on the basal ganglia, giving a soap bubble appearance with this pseudocyst. This is cryptokorosis, right? So I hope you are all comfortable with these conditions, right, associated with HIV. Let me just ask you a few things again. Can you answer this one? A HIV positive patient who is showing bilateral asymmetrical lesions predominantly involving the parieto-occipital region, involving subcortical U fibers. What comes to your mind? Try to answer this one. A HIV positive patient showing on MRI, showing bilateral asymmetrical lesions involving the parieto-occipital region, involving the subcortical U fibers. What is your answer? Can you tell me what do you want to go for? Do you want to go for progressive multifocal leukoencephalopathy or HIV encephalitis? What is your answer for this? What is your answer? Progressive multifocal leukoencephalopathy or HIV encephalitis? Waiting for you. Asymmetrical, parieto-occipital, involved subcortical. I showed you the image, right? Waiting for your answers. What do you think is this? Very good, Arun. This is PML. This is PML, progressive multifocal. Very good, Vinit. Right? Progressive multifocal leukoencephalopathy. Bilateral, symmetrical, periventricular white matter, associated cerebral atrophy, sparing of subcortical U fibers, right? Just periventricular, right? Sparing of subcortical U fibers. What do you think is this condition? This is HIV encephalopathy, right? So this is HIV encephalopathy. So asymmetrical, parieto-occipital, involvement of subcortical U fibers. Either on the image you can appreciate that, or on, they have mentioned you on the text there that there is this asymmetrical involvement, patchy involvement. Think of progressive multifocal leukoencephalopathy. And if they mention you periventricular involvement, sparing of subcortical U fibers, or they show you those images, right? HIV encephalopathy. I hope you remember I've given you an image together, which is PML and which is HIV encephalopathy. Once again, periventricular, right? In sparing the subcortical U fibers is HIV encephalopathy. Parieto-occipital, multifocal, right? Patchy appearance, involvement predominantly the parieto-occipital region, involving the subcortical U fibers also. The peripheral subcortical U fibers are also involved in PML, right? And this, what is this? Ring enhancing eccentric target sign. Where do you see this eccentric target sign with a lactate peak? Which one was that? Eccentric target sign with lactate peak, right? Especially at the basal ganglia, eccentric target sign. Do you remember that? I taught you this. HIV patient showing eccentric target sign having lactate peak. What was that? Just now I've taught you. You've seen the images also. Ring enhancing lesions, small lesions, less than 4 centimeters in the region of the basal ganglia. This is again same, toxoplasmosis, right? Toxoplasmosis. What about a ring enhancing lesion showing lesions which are large, more than 4 centimeters, periventricular? Now, the problem is the toxoplasmosis and the primary CNS lymphomas, they are close differentials. Okay, you need to understand. Sometimes, primary toxoplasmosis and primary CNS lymphomas, they are, close differentials. You need to be very careful. Both of them are ring enhancing. Both of them occur in HIV/AIDS patient, right? So be careful with the words given to you. A lactate peak or a choline peak, right? Whether it is hyperdense on CT, involvement of corpus callosum, how is the size of the lesion? Is it large size or small size, right? So all of this will help you differentiate a primary CNS lymphoma from toxoplasmosis. So if you are given a ring enhancing lesion, solitary lesion, periventricular location, involvement of the corpus callosum, more ependymal involvement, corpus callosum involvement, hyperdense on CT, choline peak, this is primary CNS lymphoma. And dilated perivascular spaces, gelatinous pseudocyst, the virtual Robin spaces are dilated. You see those soap bubble appearance. That is classic of a cryptokokomas, right? Cryptokorosis, right? So these are important things that you need to remember with HIV. So I hope neuroradiology related with HIV infections are clear to you. and also you understand the JC virus causing progressive multifocal leukoencephalopathy, HIV encephalitis caused by the HIV virus, the other toxoplasmosis and other infections that we discussed, right? The primary CNS lymphomas can be associated with Epstein-Barr virus and Cryptokorosis, right? So these were important topics that I wanted you to understand with HIV. This is a very, very important topic for your clinicals also, and even in your patient care. This information that you have learned today will help you. I hope you enjoyed this session, and shall we do one more question, or are you comfortable so far? Are you okay with all of these topics? Are you all clear with HIV, right? And its CNS manifestation that we learned with the imaging, right? So shall we try another question, another clinical case? Will you be able to handle that? Let me see if you can get this right. Okay, let me try something easier one. Let me see if you can answer this. Let's see, guys. Chalo, let's do this. This last one. An 18-month-old boy with multiple skin lesions, a developmental delay, and seizures has an MRI brain, which demonstrates multiple small nodules, which are iso-intense to the white matter on T2 weighted imaging. Let's read this slowly. There is a young 18-month-old boy. There are multiple skin lesions. There is developmental delay and seizures. On MRI brain, you are seeing multiple small nodules, which are iso-intense to the white matter and project into the lateral ventricle. There is also a small well-demarcated mass at the foramen of Monro, which is very white or hyperintense on T2. It also displays uniform enhancement. What is the likely diagnosis? Is it NF1, NF2, tuberous sclerosis, or von Hippel-Lindau syndrome? What do you think is this child suffering from? Anybody wants to try this? Waiting for your answers. Can you guess what this could be? Let us try to look at some images. I got one answer as NF1. Anybody else wants to try? Okay, so there is no toxoplasmosis here, right? In the options. So any more answers? Anybody wants to try? Let us go back to the question. Let us see. Look at here. These are small nodules that are projecting into the ventricles, right? And these are calcified on a CT scan. These are subependymal nodules, and these get calcified, forming this subependymal calcifications, and you get this candle dribblings, right? So they said there are small nodules which are projecting into the ventricles. Okay, they called as candle dribblings, and you can see the same thing here. These are the candle dribblings that you have, and there is a lesion which is intensely contrast enhancing, and location was important at the foramen of Monro, where the two lateral ventricles open into the third ventricle. Here, this is the lesion. This is the area of the foramen of Monro, and you have a lesion at the foramen of Monro. This is SICA, right? SICA, subependymal giant cell astrocytoma. And where is the location, guys? Where is the location? At foramen of Monro. This is classically at foramen of Monro. So, if you have a patient who is showing seizures, right? So you have the Vogt strad, right? So what's the Vogt strad? You have seizures, epiloia, right? Epilepsy, low IQ, and angiofibromas. Epilepsy, low IQ, and angiofibromas on the face. There will be many skin lesions. You also have Ashleaf macule, right? Hypopigmented patch over the trunk, right? So there will be a lot of skin lesions. Angiofibromas on the face, ash leaf macule on the trunk, right? Ash leaf macules are very common, the most common finding of tuberous sclerosis. So you will see skin lesions. It is not just because of skin lesions. Many of you have answered as neurofibromatosis, right? But be careful. You do see skin lesions in tuberous sclerosis. The most common finding of tuberous sclerosis is a hypopigmented patch on the trunk, the ash leaf macule, and you are seeing the subependymal nodules. You are seeing the SIGA, right, the subependymal giant cell astrocytoma, which is located classically at the foramen of Monro. So this is tuberous sclerosis. So let me show you few more things in tuberous sclerosis. You have these cortical tubers, which will cause seizures in the patient. There will be some radial bands. So in the brain, in tuberous sclerosis, you remember you have these subependymal nodules like this, right? You have radial bands, you have cortical tubers, and there will be SIGA. So remember these four things. There will be cortical tubers, right? Tuberous sclerosis, right? So cortical tubers, there will be these radial white matter bands, radial bands. There will be those subependymal nodules, and at the foramen of Monro, you will see SIGA. In the lungs also, these patients in the lungs also will show lot of cystic dilatation, especially female patients in the terminal stages of the disease. There will be cystic dilatations in patients of tuberous sclerosis. This is nothing but lymphangioliomyomatosis. In the kidney, you will see fat containing lesion. Okay, a black fat containing lesion will be there. This fat containing lesion in the kidney is angiomyolipoma. Angiomyolipomas. In the heart of these patients, these patients may have arrhythmias because in the heart, these patients may have a lesion called as rhabdomyoma. So remember, these all can be seen in tuberous sclerosis. So if you look at tuberous sclerosis, remember it as 3As. 3S. Ash leaf macule is the most common, so we'll write it first. This is the most common. You have angiofibromas, previously called adenoma sebaceum, but those are not glandular, they are not sebaceous, so the name is changed to vascular angiofibrosis. It is vascular and fibrous, so the name is changed to angiofibroma. Previously, they were called as adenoma sebaceum. Right? You also see what is the other A? Angiomyolipomas. And these are usually bilateral in the kidneys, bilateral angiomyolipomas. There is what is one as subependymal nodules and calcifications, right? You have SIGA, subependymal giant cell astrocytoma. You have shagreen patch, connective tissue patch, right, at the lumbosacral region. And in these patients, you also see around the fingers, right, around the periangual regions, these will be periangual fibromas. What do you call that? Periangual fibromas. These are also called as Conen tumors. So this is all about tuberous sclerosis. So you have lesions in the brain, right? The cortical tubers, radial bands, subependymal nodules, SIGA. You have lesions in the lungs, the cystic dilatation of the lymphatics called as clearly now? Am I audible now? Is it audible now? Still no sound? Can you hear me? Yeah. Chalo. Let's go forward. NF1 and NF2. So once we have done with tuberous sclerosis, let us look at these other options that were given to you. Right? NF1, NF2, right? Von Hippel-Lindau syndrome. Let us revise. You must be knowing this. First learn NF2, right? So first learn NF2, right? NF2 is nothing but miss me lesions, right? So miss me. First learn NF2. Multiple inherited schwannomas, meningiomas, and ependymomas. So anything which is miss me, right? So multiple meningiomas are seen in NF2. If they ask you a patient having multiple meningioma, what should you suspect? NF2. Bilateral acoustic neuromas or bilateral vestibular schwannomas is also NF2. So remember this very useful mnemonic, miss me. So first learn miss me. And anything other than miss me is NF1. So whether you have a patient with Crow's sign, the axillary freckling, right? You have plexiform neurofibromas, okay? And you have optic gliomas, usually more common with NF1. Anything other than, miss me is generally NF1, like pseudoarthrosis of tibia. Any musculoskeletal disorders that you have, like, sphenoid dysplasia, the greater wing of sphenoid is dysplastic. This will give you what is called as a bear or bit sign. In radiology, I taught you all of this, the bear or bit sign that you have, right? So sphenoid dysplasia or the bear or bit sign, ribbon ribs you have, scoliosis, any musculoskeletal defects that you have, right? They generally a lateral meningocele. All of these are features of NF1. So NF1 will have leash nodules, iris hamartomas, right? So all those things. Anything which is not miss me. Anything which is not miss me, answer it as NF1. If you have to compare between NF1 and NF2. So if they ask you plexiform neurofibromas are seen in, or pseudoarthrosis of tibia, sphenoid dysplasia, bear or bit sign, anything which is not miss me, answer it as NF1. What about von Hippel-Lindau syndrome? Lastly, von Hippel-Lindau syndrome. Remember 3 letters, so chromosome 3 defect, right? And chromosome 3 is also with clear cell RCC. So bilateral clear cell RCCs you will have, right? Bilateral clear cell RCC. You also have retinal hemangioblastomas, right? And cerebellar hemangioblastomas. So let us do this like this.